All right, we will go ahead and jump in today. Um, for today's session, we are going to be looking at partnerships, clinical rotations, and residencies, and really specifically looking at nurse practitioner and mental health nursing. And as always, if you have any technical issues, you can send a message to Mariah and she will get you sorted out. And we're here on behalf of the Association of Clinicians for the Underserved and our STAR Center program. And so any recruitment or retention needs, feel free to reach out to us. We're also happy to offer one-on-one TA sessions and just answer any questions you might have. And then here's the STAR Center team. And today you have myself and Mariah. And like I said, today we are going to talk about options for building out programs for nursing, nurse practitioner, nurse midwife, and psychiatric and mental health nurse practitioners, and kind of understanding the opportunities for collaboration and training with educational institutions. So I wanted to start off with a quick discussion question. And it looks like we just have Joan and Susan with us today. But do you all have any thoughts? I couldn't remember. I know at least one of you, your health center operates an HPET program already. Is that correct?
Yes, we do. We have quite a few students.
Okay, and remind me again, what type of students are they?
I work at Southwest Community Health Center in Bridgeport, Connecticut, and we have, we have nursing. We have a preponderance of nursing, mostly APRN students, some BS to RN to BSN students. We have PA students, we have some medical students, we have among the nursing students, I don't think we've really, well, we occasionally have a midwife student, but psych nurse practitioners. We also have medical assisting, did I say that already? And we have, what was I gonna, occasionally we have a dental student, and we also have the first school of dental hygiene is here in Bridgeport, and we have hygiene students on and off, but groups of them when we do. Lots of different kinds of students.
Excellent. And I'm kind of curious, are they primarily through a partnership with one institution, one educational institution, or do you take them from several different universities or colleges?
We take them from, we've had some grant funding and sort of contracted relationships with 2 schools in particular, but we take them from multi-schools, mostly schools near us. I guess I would say primarily from 3 different schools, but we have a couple of community colleges with medical assisting students and nutrition aid students. We have, and then, we have occasional students from other universities and sometimes occasionally from online programs. We don't sort of favor that, but if we have a slot and we have a student and we can get the arrangements that we require, then we have had some online students as well. I mean, they're not online to us. They do their rotations with us, but they're online with their student program.
I just pictured someone walking around with an iPad. And,
Well, hey, I mean, there's been a lot of that, as you know, in the past couple of years. But one requirement, we have to have an affiliation agreement signed between the 2 institutions, of course. But we also, and maybe everybody requires this, but we do require that the school, not just the student, provide professional liability insurance. And sometimes we find with online programs, schools do not do that. And so we don't take their students, end of subject.
Okay. Interesting. Well, yeah, thank you for sharing. And yeah, would anyone else like to share if you already have an HPET program or if you're planning to put one in place, kind of partners that you work with and what that partnership looks like, or the types of students you have, or just partnerships that you wish you had, like what in your ideal world would be the type of partnership you'd work out with an educational or training institution?
Yeah, I can talk about what we do. We currently have educational affiliation agreements with 2 different health systems for their residency programs. Those are hospital-based residencies, with a university for residents in optometry, and with a medical school for their students to do their pediatric rotations with us. So our community obviously has a lot of medical training going on. 3 different hospital systems that have community-based residency programs, a health science center that has a university-based program. Our goal is to develop a consortium with 1 or more of those institutions, an actual legal consortium, so that we can apply for accreditation of a community-based residency program through that consortium, and get some of the HRSA and federal funding that's available to health centers or consortiums. So that's where we are with medical education. We don't do as much with nursing education. We do have a local vocational school and community college that send medical assistant students, but we don't have any nursing students. Although there are 2 nursing schools in our community, and the health science center that we frequently work with is starting a new nursing program. So we're not interested in starting a nursing school, but that would be another area where we would really like to see better partnerships for training nursing. I think the biggest barrier for us is that we have such a hard time keeping nurses ourselves, that we have felt really constrained to offer much nursing training because the few nurses that we have not been here a long time, and are maybe are just not comfortable or ready to precept other nursing students.
Susan, what is your practice again, please?
I'm sorry.
What
did you ask?
what is the organization that you work with?
I work for an FQHC.
You do, but you don't have a lot of nurses. That's interesting.
We have a lot of medical assistants, but not a lot of licensed nurses.
Okay. Yeah, actually, I don't think we have a lot of, I mean, we don't have a lot of licensed nurses, but we do have, a lot of our providers are APRNs. We have a lot of school-based.
Yeah, we do have a lot of advanced practice nurses. Well, not a lot. We have, I think, 5 or 6 advanced practice nurses. But again, we've had quite a bit of turnover in that area, and none of them really feel like that they want to precept other advanced practice nursing students.
Where are you located, if I may ask, Susan? Sorry,
In Fort
Joan.
Worth, Texas.
Okay.
It was hard not to guess that.
Yeah.
Yeah, I would say many of the folks here that precept are APRNs. That's probably the largest category of our preceptors. And we do have some turnover, partly because some people come and they're here on National Health Service Corps periods and they don't stick around, and some do stick around and love it, but for some it's more an obligation, I would say. Is that part of your turnover as well?
I actually know our turnover is really more just based on demand in the community and market-based turnover. Even though we've signed up with the National Health Service, I can't think in the last 3 years that we've had anybody that was here for National Health Service
Really?
loan forgiveness.
Yeah, we've had nurses, physicians, dentists.
Yeah, I'd imagine in Susan's situation with that many hospitals and everything around, it's hard to,
Yeah,
Yeah,
it's
to
an
qualify.
incredibly competitive environment
Yeah.
for health service workers of every kind, all the way
Did you-
from doctors to medical assistants.
Did you say what part of Texas? you're from?
Fort Worth, which is in the
Dallas, yeah.
what's called a Dallas-Fort Worth Metroplex. So we're
Yeah.
really near Dallas. It's a metropolitan area of several million people.
Sure.
and
Several million people is the state of Connecticut, so it's very different world.
Yeah, yeah.
And yeah, thank you for sharing. And I don't want to interrupt the conversation. I want to give anyone else from the group
Sorry.
that wants to. Oh no, that's okay. It's a great conversation, and I think we'll have some time at the end as well. But I want to make sure that April's able to present and then have some time for questions and everything, because she has a lot of really good information. So we'll take about 2 or 3 more minutes if anyone else has anything they'd like to share, and then we will jump over to April. Okay, let's see. So with us today, we have April Phillips, and she is a doctor of nursing practice. And Dr. Phil, is that correct? I didn't mess that up.
You are absolutely correct. Thank you, Alex.
No worries. And Dr. Phillips has dedicated her career to the provision of mental health services to underserved populations in need. So as a National Health Service Corps ambassador, she has collaborated closely with several members of Congress and former Governor Susana Martinez of New Mexico to increase the availability of mental health services in rural and underserved communities. She maintains a current clinical practice in southwestern Colorado, working with clients of all ages. She integrates several therapeutic modalities into her practice and is a DBT certified practitioner. She is also currently working on a certification as an EMDR provider as well. And so I will turn the screen sharing over to April and let her share all of her wonderful wisdom with everyone.
Thank you, Alex. That's very kind of you. I'm really glad to be a part of this group. Before I begin, I just want to thank you all for taking the time out of your very busy day to join me here today. I realize that the business of healthcare can be very busy, particularly post-COVID. So since we do have a smaller group, I'd really like to make this a little bit more interactive in presentation style. So couple different things. If you have questions, if you'll just go ahead and raise your hand or just chime in as we go along. Want to make sure that I address any questions that you do have. And if you feel more comfortable, you can also put those questions in the chat as well. And Alex will let me know and stop me as I go along. So really when I thought about this presentation, the thing that came to mind was really, how do we build bridges? Not only how do we bring those valuable levels of expertise, whether they be MD students, DOs, dentistry, nurse practitioners, physician's assistants, all of those valuable providers across the board. How do we not only attract those providers, but how do we create an environment that's truly sustainable over time? How do we keep those folks? And how do we keep that continual pool of candidates? So just a few objectives that I hope to meet with you today. Upon the completion of this presentation, we're going to talk a little bit about some of the practice-based gaps. When I think about practice-based gaps in reference to this type of situation, it's really more, how do we look at that gap analysis, right? Where are we at? Where do we want to be? And what's in between? So we'll talk a little bit more about that. I'm also going to present you with a great example of an academic partnership and just discuss how academic partnerships may be implemented, the most optimal way to do so, and how do we really attract and retain those candidates. And I also want to touch base on the increased need for diversity in our workforce. I'll talk a little bit more to the statistics related to these issues, but we are starting to recognize that we have many patient populations that are unrepresented within our provider pool. So just to talk a little bit about those practice-based gaps, this is probably some things that you are all very familiar with, but I think it's really important to open up the discussion. We are seeing a great deal of attrition in medical providers. We're losing candidates not only on the educational end, enrollment in medical schools and advanced practice schools, but we're also seeing people leave the practice for a variety of different reasons, right? We've got an aging population of providers, but we've seen a great decline post-pandemic as well. I want to touch base on a really important issue to me, and I think it's very relevant to the discussion, and that's the financial cost to our providers as they enter this field. I also want to touch base and get some feedback from you all regarding the financial cost to you as healthcare organizations, particularly in the realm of federally qualified health centers or those institutions that offer sliding scale services, and maybe you're working with a greater Medicaid and Medicare population. I think that's really important. And we'll also talk a little bit about the need for increased diversity in our workforce. And I'll talk a little bit about why that's become so very important. So when we look at the attrition of medical providers, there are several issues that come into play here. We do know that the US healthcare system has lost 500,000 workers since 2020, which co-aligns with the pandemic. We also know that 47% of healthcare workers have reported, and this was in a recent large-scale study, that they plan to leave their positions by 2025. I mentioned a little bit about the aging workforce of providers. This was very striking to me in particular. Almost half of all physicians and advanced practice nurses are over the age of 55. So that's really important, because at what point in time do we see those folks transition out of their roles? And that's pretty quick. In response to much of the attrition and inability to access that valuable pool of candidates, many hospitals have really looked to contract labor, but when they look at their per patient cost, that has risen since 2020 by almost $1,500 per patient. So that's a pretty significant cost increase. I want to stop for just a moment. Have you all experienced a great deal of cost increase in your staffing, and are you utilizing contract labor more? Some of you in the urban areas may not need to do so quite as much. Joan?
Well, I don't really know, because I'm not in the hiring arena, but I don't think we have increased a lot of contract hiring, but I think we are experiencing more turnover and gaps of time when we're short-staffed. So I don't know if we are filling it with contract labor. I'm not really sure.
Okay. And when you're seeing that turnover, have you kind of done a focus analysis? Are there particular obstacles that you're facing in that realm?
I would have to really ask the people, like the nursing director and the medical director. I'm not sure.
Thank you. Appreciate your information.
But by the way, I will just add that one thing, a suggestion was made recently by our head of HR, which was we should have gatherings of our students a couple times a year. And I think we're going to build on that. in order to make them feel kind of more part of the family and interest them in coming to work with us. So it all ties in.
Yeah, I love that idea. That's music to my ears as a clinical director. And I'll mention some ways that we've utilized that type of interaction with our students and the organizations that we work with through our grant
Great.
program. So,
Right.
anyone else before I move on? Alex, it looks like we've got something in the chat, a comment.
Oh, that was just me letting people know they could weigh in the chat if they wanted. I know Casey, I think, had unmuted a moment ago.
Yeah, I was just gonna say, and I'm here in Montana, living in healthy Great Falls. I'm actually traveling for work now, so I apologize. I had some technical difficulty getting on time. Our costs have substantially increased. I mean, on the provider rate, I think we've seen a 30% increase in provider compensation just to get people in the door. We've had to increase our frontline staff for the last 5 years have had I think our corporate minimum FQHC corporate minimum wage has gone from like 12 in 2014, I believe, to some more than 5 to 10 years to $18 an hour. So, and 3 of those dollars have been in the last 36 months, just to remain competitive in our market for frontline staff, and sort of commensurate things from patient advocates all the way, through RNs. We are definitely have to be competitive with the local hospital system on our ends, and we can't be as competitive, but we also have to push the quality of life work factor of working in a community health center versus shift work. As the son of a afternoon shift nurse my entire life, there's a quality of life difference. The dollars, you get trade-off for sure.
Great points. Thank you so much, Casey. Are you finding that you're utilizing things like sign-on bonuses and that type of thing for retention?
Yeah, and even outside of on the medical side, even in the world of like dental assistants. So in Montana, dental assistants do not, and I don't know if they do other places, but they do not have to be licensed. It's a on-the-job training situation. But you have dental clinics giving essentially what is a frontline dental staff person $5,000 signing bonuses, which for their pay scale socioeconomically, that's just out huge for what they actually make on an annual basis. So that's a 10% or 20% sometimes sign-on bonus or something. So my math's right way off there. I apologize, but they're big.
Thank you. That's a very interesting perspective. Appreciate your input. Any other thoughts or comments on the topic? And do feel free to raise your hand if I miss you. Alex is going to keep an eye out also on the chat, and we'll make sure we get your questions addressed. So when we think about the financial burden to providers, the struggle is real. Undergraduate tuition has increased by as much as 200%. I've read some figures that since the early 1980s, that tuition has increased almost 900%. Today's student is facing a much more complex academic environment, right? And it's interesting to me, the feedback that I receive from the student of today, or particularly those millennial students who are entering graduate school. They really want more bang for their buck, right? They realize that they will have a great deal more student loans. They do tend to see this as more of an investment, a financial investment. And so they're looking for that ROI on their educational investment. 90% of health science students graduate with debt. We do know that the average debt load, and I would even venture to say that it's likely even higher than this, but recent study found that physicians, that's around 200,000, and for nurse practitioners and physician assistants, it runs about 85,000 roughly. Now, when we look at private institutions, Vanderbilt or some of the R1 institutions out of state, that debt is certainly going to be much more high. So when we talk about that loan repayment, I know that came up in the initial discussion. And it's interesting to me, I think, Susan, you had mentioned that while you offer that, you don't see people taking advantage of that. So that can be a very, very positive draw for students and really retaining those folks in your environments, particularly FQHCs, tribal health clinics, that type of thing. It really helps to open the door. However, as a National Health Service Corps ambassador, sometimes I have seen that there's a disconnect in connecting those students, those viable candidates, with the organizations. And I think we could do a much better job of doing that. So the burden to healthcare organizations. It was estimated that hospitals recently spent $97.3 million compared to $82.7 million in 2016. This is post-pandemic. Really, rural hospitals have taken a great brunt of the financial burden, and they found it very difficult to compete. South Carolina, which was the highest state to report an increase in staffing shortages, reported 29% of all hospitals with a critical staffing shortage. So that really speaks volumes.
April, I'm sorry, what do those figures represent? 97.3 million in what? Towards
So,
what?
so that would be the cost of care, the overall cost of care. So really, when we talk about that per patient cost, this is looking more at the cost of staffing in particular. Thank you for that question. Any other thoughts or questions that you have, Joan? Yeah, so we're seeing a great deal more expenditure on the financial end post pandemic. And I do see that in those rural underserved areas where we're really, they've been hit pretty hard. So we've had more attention on the need for diversity in the medical workforce recently. It's very interesting to me that as many as 40% of Americans do identify in a group that would be other than Caucasian or within that minority group as designated by federal guidelines. But yet we have fewer than 15% of mental health providers who fall into that category. So when you talk about those really important points of connection from a cultural standpoint, and understanding the needs of a population, it can become much more difficult. This is something that saddens me very greatly. I have worked with a number of Pueblos, tribal organizations, and Indian Health Service on a personal level, and we know that the suicide rate is extremely high for adolescent Native Americans. And this has doubled, it is double that of Caucasian adolescents right now, which is extremely high. So when you think about not only the fact that our adolescent population is demonstrating a significantly higher suicide death rate, when you look at the Native American population, it's important to realize that this makes up a very small percentage of the overall population. So that makes that statistic particularly striking. We do know that suicide is the second leading cause of death for young African American males. And I've seen this in particular in my own state. I live in a rural area of Colorado, but those students, those adolescents that do identify as LGBTQ have reported that they have seriously considered suicide. When we look at our transgender population, those statistics within my state were even higher. And many had reported that they had attempted suicide within the past year. So this really speaks to the need for those incredibly valuable mental health services. And I know I'm double board certified in family practice and psychiatry. Really my drive to work with underserved populations when I was working in a frontier area of New Mexico as a primary care provider, I had patients that were driving as far as 100 miles to see me for primary care. I was their closest source of primary care. So to ask those individuals to drive another 4 hours to Albuquerque for psychiatric care was out of the issue, was out of the question. We really had to devise mechanisms to help bring those greatly needed services to the rural community. So when we talk about building partnerships, it's really important in today's landscape where we see a financial burden, not only to students, to our providers that are coming through that pipeline of workforce pipeline, the financial burden to organizations such as yourself, and also the overall attrition within that population or pool of viable candidates. We must become more creative in solving this problem. Today, I want to talk to you a little bit about the grant program that I have been directly involved with, and that is the Behavioral Health Workforce Educational Training Grant Program. We've done some really creative things, not only to utilize those grant funds to help connect those students, those advanced practice nursing students in this case, to underserved populations. And particularly this grant is focused on underserved urban populations in need, but primarily those underserved rural populations. And so we've developed some creative ways not only to open the doors for these students that are interested in working in these rural underserved communities, but to also focus on retention matters as well, which is really key, right? Because when we talk about loan repayment, you may have that candidate that comes to your facility for 3 years, but once they've fulfilled that commitment, they may move on. This is really focused on how do we build those retention efforts as well. I also want to talk about what would an ideal partnership look like between a university and a healthcare organization. I want to talk a little bit about financial considerations with regards to these partnerships and also the training needs of students. I know, Joan, you had mentioned that you're developing some programs for your students, and that's a wonderful idea because the more that we can help those students feel a part of the greater organization, the more apt they are to stay with the organization and develop a long-term career. So with the Frontier Nursing University Behavioral Health Grant, or we call it the BWET grant for short, it was really focused on providing critically needed healthcare services to underserved communities. In this case, it really focuses upon psychiatric and mental health services. And really the idea was that we would increase the number of psychiatric mental health nurse practitioners, or PMHNPs, in rural and underserved communities. When we looked at the barriers and really did research within our pool of students, the largest barrier to really going to these facilities was a financial barrier. It wasn't so much a desire. Our students reported they had a great desire to work in these areas, but that the cost of living was a strong barrier. Housing, if they needed to complete their residency hours within a rural community, that was the greatest barrier to them. So we did come up with a creative solution to that problem. And really, how do we break down those financial barriers for organizations as well? How do we address that as a university? And how do we develop those collaborative partnerships to really provide the highest level quality experiential learning experience for our students, and one that certainly benefits the clinical sites as well? So through this grant partnership, we developed a series of, and I was particularly involved myself in the development of a series of partnerships, clinical partnerships across the nation. I'm going to take us back one slide for a moment. And really the idea was that we would have a national footprint, right? So that within a given region, any of our students could go to one of these partnership sites. Now, I do want to point out that In this particular situation, this has no exclusivity and requires none of any of our clinical partnership sites. And I think that's very important, because if you're looking to, say if you're in a rural underserved community and you really want those students that are going to be more apt to stay within your community, we do know through research that that tends to be individuals maybe that grew up in a rural community, or those that may understand the particular needs of those communities. So that was a really important factor. So by limiting that collaborative agreement, that, there was a great concern that that could exclude students in particular. So when you look at those alliances, I've seen more and more alliances with exclusivity, say in an urban environment. We see quite a bit of that in the Denver metro area. But unfortunately, that tends to attract a pool of students that want to stay in an urban area versus want to branch out and work in those underserved communities, want to work in those federally qualified health centers. So that can be a challenge. Did we have a question in the chat, Alex?
Yeah, Joan asked who the funding organization is for the grant. Is that Frontier University?
No, this is actually a $1.9 million grant that we received through HRSA. And this is a grant that will continue through 2025. And we hope to renew that. We've had great success thus far. So this is one of our partner sites, which has been a wonderful arrangement. Mountain Comprehensive Care Center, which is located in rural Eastern Kentucky, has a network of clinics, and they've expanded to 40 locations in Kentucky. The vast majority being in underserved rural communities in particular. We have successfully paired 8 to 10 students per year. So it's not a huge scale, like you'd see with an R1 larger university, but we have connected those 8 to 10 students per year with the organization. And through the grant funding, students have been able to go to this rural location, and they've been able to stay for a period of time. And thus far, although we've only got about a year and a half, we're about a year and a half into the grant, we're seeing that over 80% of the students that participate in this program are staying at those organizations and have accepted positions at the organization. I think another point of research, which will be very valuable, we do plan to look 5 years down the road, 3 years, 5 years down the road, to see what those retention rates are as well. But thus far, we've had great success. And this is a comment from Miss Amanda Haney, who is the Assistant Mental Health Director with Mountain Comprehensive Care Center, just speaking to the value of that partnership. They have had to be very, very creative in the provision of mental health services to their clients. I don't know if you all are familiar, but Eastern Kentucky in the past year was hit very, very hard with flooding in many of their small towns because of the geographical structure of many of the small towns in Kentucky. They tend to be in what they call hollers. So that'll be in between mountains. So they were more apt for flooding. So many towns and clinic centers were completely decimated through the flooding. So they had to become very creative with the care that they provided, and our students were a big part of that. So that's very exciting. We also have a partnership with Canceller Health, which is located in rural Kentucky as well, in Hopkinsville, which is, gosh, about 3.5 hours south of Lexington, Kentucky, in a more mountainous area. Interestingly enough, this particular clinic system does have a primary focus on LGBTQ needs. And so our students have not only been able to work within that underserved community. They've also received a great deal of specialty education in working with those types of patients as well, and also in the treatment of alcohol and substance use disorder, which the clinic does also specialize in. And Dr. Kanzler has taken a great many number of our students. I'm happy to say in this particular clinic, they have hired about 90% of the students that have been assigned to the clinic, which is phenomenal. Those are phenomenal numbers. And these students thus far have stayed on board and do plan to, based on our surveys, do plan to stay. So this is exciting, but I think down the road to see those retention rates will be very helpful as well. So this was a $1.9 million grant that was provided over the course of 4 years. There are several awards that are given per term. Year one, we had 30 students that participated in the program. And of those 30 students, 50, they worked in 50 medically underserved areas, 14 rural areas in particular. Over 75% of all respondents surveyed are working at those clinical sites. And we have seen that rise. When we look at that 18-month figure, that's now over 80%. So thus far, it's been very, very positive. And 11 of these students are working in the realm of substance use disorder treatment in particular. When we looked at the grant in particular, and we looked at those financial burden, that financial burden for our students, and students identifying that barrier in housing and things, we did decide to provide stipends for these students, and those stipends must be exclusively used for living expenses during their clinical rotations. And we found that once students were able to go to these underserved communities, become a part of that community, they wanted to stay. So that was really a key piece. And I think that was a great decision to do that. Any questions thus far? When we look to the training needs of the student, ideally when the university looks to that type of partnership, we would want to provide a wide range of clinical experiences for the student. The psychiatric mental health nurse practitioner program in particular is a degree that's designed to prepare our students to see clients across the lifespan and to see a wide variety of patients. So in the clinical requirements, they are required to complete a certain number of substance use disorder treatment visits. We do require that all of our students, prior to entering the clinical environment, do have that certification with MAT treatment. We know that a lot of that has changed over time, but our students do come to the table with that certification and training. So I think that's very important. And really, I think it's ideal to enable the student to work with a variety of providers, particularly in the realm of psychiatry. Unlike primary care, there may be several different ways to approach the same problem versus a rote algorithm in particular. And as such, it's really important that those students be able to see how different providers approach a given clinical diagnosis. That's the best learning opportunity. And we've really found that ongoing mentorship and support really equates with career longevity. Within our program at Frontier Nursing University, for example, we have a series of mentorship programs that are closely intertwined within our program. So students that are just entering the program will be connected with students that have completed the didactic portion of the program and are entering the clinical realm as well. So they can see their perspective later in the program. So it's almost like you're connecting a freshman with a senior, and they get that feedback, suggestions, and guidance and support throughout the program. Unlike some other programs, and this facilitates this mentorship program, unlike other programs, our program is designed to front load all of the didactic coursework. So when our students enter the clinical environment, they've had all of that academic training from a didactic standpoint, and now they move to the application process within the clinical rotations. So when we look at breaking down financial barriers for organizations, you know, and I've heard this from you all today, that turnover is a very, very significant problem. And it's a costly one. You know, they say that it costs 2 to 3 times an annual salary to replace those providers. And when you look, you know, when you're looking at people at the graduate and doctoral level, it's harder to find those candidates, right? And then when you get those candidates, it's harder to replace that. So that may be even costlier from a financial standpoint. The cost of hiring short-term workers is certainly very significant. Many agencies, you know, when you're looking at filling that gap, as Susan had mentioned, where you're unable to hire another qualified candidate, that cost can be significant, and it can really drive up your hiring HR costs. We do know thus far with this grant program, there are a higher percentage of these providers, potential providers, that are going on to work at the facility. And to me, that's very exciting. We have had great satisfaction rates thus far within our grant partner sites. And I think a good part of that has been the ongoing support that we provide within the program to our clinical sites from an organizational standpoint, but also that this pipeline of future providers has been provided to the organizations. And what better interview process than to see a candidate in your clinical environment over the course of 4, 6 months, 9 months, right? You get to see not only their skill level, but you also get to see, are they a good fit? And that's very important when you're looking at a long-term relationship with the future employee. So just a few things that we offer within this clinical partnership. It's that streamlined placement of students. This may look different to each organization based on their individual needs. But we do offer ongoing support, training for our clinical partners, preceptors, and students during this experiential learning environment. That might look like no cost CEU courses for our providers. All of our clinical preceptors are able to attend our diversity, equity, and inclusion conference at no cost. And that has been a very valuable asset for our providers and clinical partners. And really, it's that potential recruitment pipeline that's been opened up for the organizations. Because the grant is also focused on the expansion of providing a more diverse and inclusive workforce, this has been another positive gain for organizations as well. And addressing that need when we talk about those underrepresented populations, this has helped to bridge that gap. Another part of the program, we've provided access to some national organizational training to our students. So some of those funds have been set aside for scholarships so that our students can attend conferences such as the American Psychiatric Nurse Association annual conference. So this broke down, again, those financial barriers for our students because they're paying tuition, they're paying for books. Many of them, because our program is exclusively at the graduate and doctoral level, many of them are working as well, either as a nurse or they may be an advanced practice provider as well as they enter our program. Any questions thus far? Thoughts or feedback? Yes.
I do have one.
Yeah.
We don't consistently get feedback from the universities that we work with to us as a clinical site. And I just wonder, have you formalized the feedback to them?
We have, absolutely. So within our program, we have a mechanism which promotes more feedback. We do have a designated faculty member. The title is regional clinical faculty member. So they are regionalized within the United States, but they're in contact with the clinical preceptor themselves on at least a monthly basis. So they meet with those clinical preceptors to see if they're facing any difficulties, if there are any things that we can do as a university to help support their efforts in the clinical environment. I myself, as the clinical director, have been closely involved with each of the partner sites on a one-to-one basis. And I do meet with all of the clinical partnership sites on a quarterly basis. So every 3 months, I'll go out to the site, meet with leadership to address any particular needs or concerns that they may have. Did that answer your question, Joan?
Well, yeah, and that sounds more regular and consistent than we get. I mean, we do, well, we certainly hear if there are problems, but from the universities, and we get there's a person attached to each of the students, depending on the discipline, that meets with the preceptor, once typically, at least from our most regular schools that we work with. But then we don't necessarily hear feedback from the students as well at the end of the cycle. I know that they have to do an evaluation to the school, but then we don't get that feedback from the school. And I wonder, do you provide student-based feedback or just faculty-based feedback?
We do. And I love that you're bringing that up because that is something that I've been personally involved with and working on. And I think the development of these collaborative relationships certainly helps to facilitate that. We do survey our students at the end or completion of their clinical rotation. We do also require within our program something called a mid-clinical site visit, where the faculty member will actually go to the clinical site in person. Sometimes if it dictates, that may occur virtually per the request of the clinical preceptor, but at that point in time, they are able to meet with that clinical preceptor and discuss student areas of strength, growth, any particular needs of that preceptor and feedback there. And then they'll meet also between the student and the clinical preceptor together. But at the end of the rotation, we do have a mechanism in our curriculum that does connect that faculty member with the organization as well, so that you get that student level feedback.
That's probably the one piece you described that we don't really get. And that would be informative for me as the person that does the parent too.
Yeah, thank you. That's a great point.
Thank you.
Absolutely, absolutely. So when we look at an ideal clinical partnership, good communication is integral to that piece. Again, when we're looking at underserved communities, retention is key, right? You need to have a pool of candidates or a pipeline pool of candidates that will not only come to your organization, that feel committed to stay at the organization as well. And that goes into sustainability over time. And one of the greatest identified barriers by organizations such as yourself has been retention efforts. We see that typically in underserved communities, it has been more challenging for organizations to retain those high quality candidates over time. And that may be for a myriad of different reasons, but this has been identified as a point of focus for HRSA in particular. So that was a big part of the grant. Did we have a question?
Are you going to talk about that last bullet? That is such a sore subject.
Oh gosh, I know, I know. Yeah, yeah, it is. It can be challenging. And you know, there's a few different ways to approach that. Um, you know, having students as they grow through that clinical coursework over time, having mechanisms as that student becomes more independent that can actually serve to lighten the provider's load a little bit. But, you know, it can be difficult when you're asking a very busy medical provider to take on a student, because I've been there, I've done that from the provider perspective. And the first thing that goes through your mind is, oh gosh, I've got to see 20 patients. I've got to see 25 patients. How am I'd love to work with a student, but how do I make that happen? So if you have any mechanism within your organization where, say, if a provider takes a student, that you can lessen their workload by X number of patients, that can really help in those long-term efforts if you're looking at increasing your pool of candidates. One way that our university has tried to offset that, we do provide a stipend for our clinical preceptors. Sometimes the organization envelops that stipend so that they're able to adjust those workloads slightly, but it's just a way of saying thank you to our clinical preceptors, because we do realize the time and efforts that are involved in working with the student. But it's a continual struggle. So it's very key that there not be a clinical cost to becoming a clinical partner in these types of relationships. I think that's very key. Also, you know, we look to that provision of a future pipeline of workers and high quality, highly trained workers. And it's a great opportunity when we're bringing those folks in. It's a great opportunity to see if they're going to be a good fit in your environment, because there's the piece of training, and then there's also the piece of, is this person a good fit within the greater organization, within that particular clinic system? How will they fit with the other individuals? Because personality does come into play, and that becomes important at the team level. And thus far, we're seeing that a high number of our students are going on to accept positions at the clinical sites. But that will be very, it'll be very valuable to see what those retention rates look like at year 3 and year 5. And we do plan, it's not a requirement of the grant, but we do plan to gather that information from a research standpoint. Any thoughts, questions, or feedback on that? I'm curious to know, amongst the group, do you happen to know of the students that come to you either from medical residency programs or advanced practice programs? How many of those students are going on to be offered a job at your organization or stay at your organization? And you can feel free to put that in the chat as well.
We don't have a high number because we have a lot of students.
Yeah.
I think I clocked over the last year, in that whole range of everything, we had like 93 students or something. And so probably not a lot of them. A few medical assistants, you know, some people not at the provider end did definitely become a match.
Yeah.
What about others?
I'd love to hear from some other folks. Tiffany, Monica, Patricia, Yolanda. Are you seeing similar things within your organization? Yeah, I think that can be very valuable information, Joan, when we're looking at that retention. effort.
And I'd be curious too to know if folks are like doing active recruiting, because even if someone is say in their second year of like a 4-year nursing program, eventually they'll be looking for a job. And so like, are they being provided materials and like, hey, when you're ready, email this person, tell them this was your preceptor, and like giving them that direction? Because sometimes a lot of times people come out of school, I know I did, and are just like, I don't know how to find a job, and I feel real weird just reaching out to an HR person, even finding their email and everything. So kind of I wonder if people are actively making that connection for students and kind of keeping in touch with them if they're not close to finishing their training.
That's a great point.
Yeah, I'd love some ideas on that. That's what, I mentioned that we're just starting to think about sort of the softer things.
Mhm.
How to just make them feel at home enough and understand the organization more than just their little silo that they're in. Well, what are others doing in that regard?
I think we've got a comment in the chat.
Oh, yes, sir.
This is Erica. Can you guys hear me?
Yeah, thank you.
So I work for the PCA here in Louisiana, and we do have a lot of nursing students who do come into, get precepted through some of the FQACs here. But of course, we have a lot of rural areas in Louisiana, and Baton Rouge is one of those areas that is very, very competitive for nursing students. So when we do retain some of the nursing staff, because a lot of our FQACs are ran by nurse practitioners. They just have to have oversight. And so we retain them that way. I think the more attractive thing about it is, of course, the being able to work in consistent shortage areas and being able to have their student loans paid for. But beyond staying for that, we don't retain them after that. So we're looking more or less going to something like maybe Doc on the Block, where maybe we can attract some providers that may be going through their gap year if they have not been matched. So we're looking at ways to kind of retain those students in that way. And then we have a lot of programs that are geared towards, reimbursement of their student loans. We have different organizations who are doing a lot of that. But because our FQACs are primarily really ran by nurse practitioners, we have a lot of nursing students that come through.
Nice. And I'm curious, how many of you currently have a mentorship type program for those newer providers? I think that can be really key in not only helping them to feel a part of the greater organization, but to also get that very important mentorship relationship.
Yes. So
someone to look to with greater expertise.
So I don't think we have a mentorship program. I would love to start one. The only kind of thing we have sort of like that is, of course, we have a clinical branch meeting where we bring our clinical minds to the table to come up with new things for all FQACs and kind of share their best practices. But we don't really have a mentorship program that I know of for nurses. I don't want to speak for everybody in saying that, but I don't personally know of it. Of course, I'm not on the clinical side of it. I'm more on the practice management side of things. So I don't really know that clinical part, but I don't have any knowledge of it.
Yeah, I think that has been particularly effective within our educational program. So I could see where that would be really effective in the clinical environment as well. Previously, I have been the medical director of a clinic system on a couple different occasions, and that was something that we set up within our FQHC system, and it really did have a positive impact. And the surveying results were very positive. People felt more aligned with the organization when they had those types of relationships. So it may be something to consider.
Yes, thank you.
Yeah, absolutely. Thank you. I really appreciate your input. So we talked a little bit about what the scholarship recipients receive. I think really that foundational funding for housing and living expenses has been really key because it breaks down, it serves to break down those financial barriers for our students. And that was really important. And once they get into those rural underserved communities, they reported that they felt more a part of that community. And I think that really helped with retention efforts as well. Few areas of special focus within our grant program include pediatric and adolescent populations at high risk for behavioral health disorders, intimate partner and youth violence. We've also focused, in particular, we've provided a number of in-services both for our clinical preceptors, but also for our students. And that really helped with that collaborative communication piece as well in providing those types of training and trauma-informed care. And really to help students to bring that into their practice. So when we talk about innovative strategies and really creating a culture of health, it's very challenging. When we looked at those retention rates post-pandemic, it's really challenging for medical providers right now. They're under a great deal of pressure. And we do know as many as 50% of primary care visits involve some sort of mental health issue as presented by the patient. So that speaks volumes. And, you know, they're really under a great deal more pressure from a time perspective and that type of thing. So, you know, a few just simple things, if you can offer like free mindfulness sessions for your providers. It can take 15 minutes out of a lunch break. That can be done on a volunteer basis. That's something that I've spearheaded at our university for our faculty members, and that's been very helpful. And we talked a little bit about some of the other strategies. Health insurance, it's a struggle. And often that's a very difficult negotiation process. But if you can provide a good benefits package, that's certainly something that providers will look to. And now I will open it up to questions. There's been some great input today. I really appreciate it. And Joan, thank you for your wonderful questions. That's been great. I appreciate it.
I don't usually
Sounds
lack for questions.
What's that?
I don't usually lack for questions.
Any thoughts or ideas after today's discussion?
Of course, I'm going to look into getting a mentoring program here in Louisiana and see if we don't already have one for nurses. That would be a good idea to kind of get that started. And I guess within the PCA, we can kind of host or facilitate those things, since we, you know, kind of sit in the middle of everything. But I think that would at least help us, you know, retain some of our nurses. They can bounce some ideas and best practices and share those things with each other. I think that would be the start of something great. We already have something for our C-suite employees. You know, we're always geared everything towards providers, but we don't think, you know, in the nursing realm for that information. I think we in the practice management department was thinking about doing a clinical symposium for them, for our nursing staff, for providers, as well as medical assistants, front desk, all of those people that don't get those skills that the providers normally get all the time, to kind of run them through their skills, find out what's new out there on the horizon for our FQHCs, and make sure that everybody's on the same page with, you know, knowing how to take proper blood pressures, knowing what's new for CEGs, knowing what's new for behavioral health. All of those things help with retention, because, you know, the provider burden is great if you have a staff that doesn't know how to take vital signs. That means the provider has to go back in the room and take vital signs properly. You know, we at the PCA go and do site visits to make sure that, you know, our FQHCs have good workflows and good practices. So those are some of the things that we observe when we go to the clinic, that, you know, if you teach one nurse in the clinic how to do an improper blood pressure, all of the nurses that she trained will do an improper blood pressure. And so, it's small things like that that can derail the whole visit. So we're thinking about doing a kind of a skill symposium just to keep everybody fresh on their skills.
That's wonderful. That's great. And another thing I did mention that really came to mind when I was in the role of medical director, I initiated a program, and even though you have a long work day, it really, really helped our clinicians and staff to come together. We would have a debrief at the beginning of the day and a debrief at the end of the day, right? What worked well? What could we improve upon? What can we do tomorrow? And it really helped to bring teams together.
That's really cool. I like that. I think that's a good time to also bring out, like you said, like what worked well during the day, or just what went well, or like how many people did we care for today? Because we lose track of like all the wins that happen in healthcare. It's really easy to
Yeah.
think like, oh, this went wrong, that went wrong, we failed to do this, like, and that gets a little defeating. And so like at the end of the day, to have that like, hey, here's what went really well, is I think helpful for that like mental health for the staff.
Yeah, and to recognize those above and beyond moments, right? When someone really goes out of their way. I think that's important.
Yeah.
Absolutely.
Any other questions, thoughts? I have included my contact information. I have an open door policy. Please reach out if you have any questions, if there's anything that I can do to support your efforts. Really appreciate all that you're doing out there in today's healthcare arena. Your work is so very important. Thank you.
Thank you so much, April. It was fantastic having you here. And
Yeah. Thank you for the
Yeah.
good discussion, not just didactic, but engaging us.
Yeah, that's my pleasure. Absolutely. I want to support everything you all are doing out there. It's important work.
no, it's
Have a
it's
great
always cool
rest
to
of your
hear
day.
what yeah. And real quick, everyone else, in April, I know you have to go. So if you need to hop off, I'll let you do that. I just want to, for everyone else, take one moment and say thank you one more time to April for being here. And then if anyone, you can use the chat, you can just let me know, or you can use like your smartphone and scan the QR code on there. Or let's see, do I have this still? And go on to the Mentimeter. So you can scan the QR code and go on to the Mentimeter if you'd like to provide anonymous feedback. But basically, we have one more session coming up in June. And I just want to take the last couple minutes today and get input from folks on, is there anything you would like to talk about in a little bit more detail next week? Any information you feel was missing or not covered, or after hearing from all the speakers we've had over the past several months has come to mind and you're like, I'd like more information on that. And I wrote down some things. It seems like maybe engaging students for recruitment would be something that we could provide a little bit more information on in our session next month. But anything else that you'd like more on, let me know. Or if it's, hey, this would be a great whole learning collaborative or a whole webinar on its own, or we want you to find a guest speaker, what will help you all the most. So that's kind of what I'm looking to collect here. We'll give as much information as we can in the final session, and then maybe build some things off of that as well if people have specific requests. Okay, yes, and absolutely. And if you think about something later on, please feel free to put it in the discussion board or send me an email, anything like that. And then I will see everyone next week. Sorry, not next week, next month. I will see you all June 20th for our final session. And if you could just take about 2 seconds here and fill out the post-session evaluation that just popped up on the screen. And then once you've finished the evaluation, I will stay on the line for a couple more minutes in case anyone wants to put suggestions in the chat. Otherwise, like I said, you can fill them in on that Mentimeter poll or just post them on the discussion board or just email me. And hopefully we'll have a good final wrap-up discussion next month. But thank you everyone for being here today. And I'm really glad we got to have so many people join. April always has really terrific information, and Frontier Nursing, for anyone that's in their region, they work with a lot of different places, and I think are a very good clinical training partner to have.